Hello, hello, friends. Today we have Dr. Howard Schubiner with us. Thank you, Doctor, for joining us. Thank
Thank
you.
you.
So good to have you. I'm going to start by introducing you with your bio. Dr. Howard Schubiner is an internist and a clinical professor at the Michigan State University College of Human Medicine and has authored more than 100 publications in scientific journals and books. He lectures regionally, nationally, and internationally. Dr. Schubiner has consulted for the American Medical Association, the National Institute of Drug Abuse, and the National Institute of Mental Health. Dr. Schubiner is the author of 3 books: Unlearn Your Pain, Unlearn Your Anxiety and Depression, and Hidden from View, written with Dr. Alan Abbas. Dr. Schubiner has collaborated extensively with colleagues such as Mark Lumney, Thor Wager, Yoni Usher, and Alan Gordon to develop 2 novel psychological treatments for chronic pain: emotional awareness and expression therapy, EAET, and pain reprocessing therapy, PRT, which have been shown to be highly effective in randomized controlled trials. EAET is now listed as a treatment option in the U.S. Department of Health and Human Services Pain Management Best Practices Interagency Task Force report. Dr. Schubiner sees patients virtually from anywhere in the world at cormandyhealth.com and lives in the Detroit area with his wife of 40 years, and they have 2 adult children.
That's all true. Thank you so much.
Yes, thank you, Dr. Schubiner. It seems like you've certainly done a lot in your life. I want to hear maybe in a little while about how you manage. Did you ever manage to avoid hypervigilance and burnout and overdoing, and what was your secret in doing this? But before we get into this also, or actually, if you like, we can start from there because I want to untangle your definition of pain. Because you're unlearn your pain is the title of our topic here today.
Right.
Yes. What is pain and how can we unlearn pain? How did you do that?
Well, first of all, thank you for your kind words. It's very kind of you. I tried to accomplish a lot, but it's just I've been around a long time, so being old, you have more time to do things. And I can't say I've ever had burnout and alienation to a large degree, but I have had pain many times in different points in my life. And when I was a younger doctor, I didn't realize that those symptoms were caused by emotional distress, because doctors in medical school are not really taught that common everyday symptoms that many patients have are actually caused by emotional distress and stress. When I was an intern, just starting my first year as a doctor, I developed diarrhea every day, and that lasted about 6 months. And I didn't know what it was caused by. I didn't think I was sick, and there wasn't anything wrong with my body or my bowel, but I was reacting to the stress of being a young doctor and worried about being wrong, being incompetent, hurting people. In my 30s and 40s, I was, trying to make a career, and I was working hard at a university medical center and seeing patients and teaching and trying to do research and having young children and a family. And my neck started to hurt, and my neck would hurt very frequently. And the doctors told me that I was arthritis and I had bulging discs. And if you look at my MRIs, I still have arthritis and bulging discs on my MRIs now, but I have no neck pain now. So it turned out that the neck pain that I was having was not due to what the MRIs showed, because it turns out that normal, healthy people have the same findings on MRIs of their necks and back. It's like getting gray hair. So it turned out, again, looking back at it, that was due to stress and emotional distress at the time. I had too much pressure on me. So, I've recovered from those things. I still get different symptoms from time to time that are caused by my brain, and that's because I'm human. And everybody has a brain, and everyone has a body, and everyone gets symptoms from time to time. So we can talk about pain if you want to go into that now. But I
Yes,
just
please.
wanted to give that kind of introduction to make sure that people know that these conditions that I'm going to be talking about are basically universal. They're not just common; they're universal. I'm sure you've had, everyone can probably think about their lives and point to times when they've had different symptoms that the doctors didn't know what was causing them.
Yes, yes. In fact, I know that you have spent some time with Dr. Sarno, and he's one of my heroes. Uh, Literally saved my life. I was bedridden, totally debilitated, and neurologists and injections, you name it. I went and high dose painkillers, and reading his book with the reference from my teacher, of course, with an extended potency of receiving it from my teacher to read. And I it just dawned on me what was actually happening. And so, but anyways, yes. So I definitely have firsthand experience of what you do and how you do it. So we want to untangle this. So yes,
Yeah.
so everyone can have that uh, insight and resolve. Please tell us, what is pain?
Yeah, Dr. Sarno had this understanding way back in the 1970s and 1980s, and he wrote books that are still best-selling and are still helping and even curing, thousands of people. It's amazing what he did, his insights, and he gets people try to pick him apart or try to criticize him for, some of the little details that he said that maybe weren't completely accurate, but his overall message is very important and profound. And what he discovered is that not all injuries cause pain, and not all pain is due to injuries. I mean, this is a very simple concept, but it turns out that our brains create what we experience, and this is called predictive processing. So we don't see with our eyes. Light comes in our eyes, but our brain, the visual cortex in the brain, creates those images. We can see in our sleep with our eyes closed. That's called dreaming, right? And what we see is oftentimes inaccurate about what's actually happening in the world. And we know this from many research studies. Eyewitness reports to crime often pick out the wrong person. Police officers often may see a gun that's not there, etc. We hear things that are not there. We hear our name being called. We feel things that are not there. We can feel sometimes our cell phone vibrating in our pocket when it's not. And it turns out that an injury can't cause pain by itself. When you touch a hot stove, it's not your finger causing pain. Only the brain can cause pain. And we know that because many millions of people, thousands of people have had the experience of having a physical injury and not having pain. So if you can have, and it doesn't happen most of the time, but it happens enough time for us to know that if you can have an injury and not have pain, that must mean the brain decides, literally makes a decision on a subconscious level within a millisecond if there should be pain or not. And we know that people can have pain in the complete absence of injury. So the stories I tell, I have a friend who shot a nail in his hand by mistake on a construction site and had no pain at all. And there was a guy in England who stepped on a nail, and the nail went clear through his boot, all the way through his boot. He had severe pain. They rushed him to the hospital. They took his boot off, and there was no injury at all. The nail went between his toes. So his brain This subconscious danger signal that's there to protect us created pain as a protective mechanism to alert him that there was danger. The brain was wrong. It wasn't actual physical injury, but it looked like physical injury. And the brain made a decision, made a choice. And so if you're walking down the street and you see something on the ground that looks like a snake, your brain will immediately have you jump back. It may be a rope that's coiled up. It's not a snake, but your brain at least protected you by acting quickly. And pain is a protective mechanism. We need pain. Pain is important. It alerts us to a problem. It's a message. And frequently, pain may be a message that there's a broken bone or an ankle sprain or appendicitis or a kidney stone. So the brain alerts us to those things by creating pain. But the brain also alerts us by creating headaches or stomach pain or back pain or neck pain when there's something emotionally distressing in our lives. And this has been shown by experimental data. Research shows that when you give someone a physical injury and you scan their brain using fMRI, and then later you give them an emotional injury and scan their brain, the same parts of the brain light up. So the pain that occurs, any pain that occurs is real. It's not fake or imaginary because people want it. It's not in their head. It's caused by their brain. And then the question is this brain-induced pain caused by a physical injury in this case, or is it caused by an emotional injury, or maybe a combination of the two? And that's the job that we do with our patients to help them determine. We don't presume, because if you go to most doctors and you have pain, back pain, neck pain, stomach pain, they're going to presume there's a physical injury. And we don't do that. We take an open mind and say, let's look, let's investigate. Let's determine if this pain is due to a physical injury or not. And research shows, if you look very carefully, and we've just published a research paper I can tell you about, the majority of people who have chronic painful conditions do not have that pain, that real pain, but they do not have that pain from a structural injury. And that goes for headaches, fibromyalgia, migraine, irritable bowel syndrome, other abdominal pain, pelvic pain syndromes, and even back pain and neck pain. Most of those people, not all, of course, you can certainly have a disease causing injury, and that needs to be checked for and ruled out. But most people don't. And that is a revolutionary statement that changes our understanding of pain and our approach to pain.
And how would one know if their pain is a physical, from a disease, something in the body, or if it's caused by their brain?
Right.
How would we know?
Good question, right? An
Yes,
important question.
It's a great question. Yes,
A very
absolutely.
important question.
Yes.
Well, we use a two-step process, and we use this in the research study that we just published for people. We evaluated 222 people with chronic neck and back pain. And if you're going to a regular doctor, of those 222 people, 99% would be diagnosed as having a structural problem in their back or neck. In fact, 98% of those people had abnormal MRIs of their back and neck. But we know, and everyone should know this, the data is very clear, that most people who are healthy and have no pain at all actually have abnormal MRIs of their back or neck. Now, these MRIs didn't show a tumor, a fracture, an abscess, something that was seriously wrong. So the first step is to rule out a structural problem. An MRI can be helpful. Other testing can be helpful. If you have headaches, you want to get testing on your brain to make sure there's no brain tumor, right? You want to make sure there's no sinus disease or ear disease or whatever. You have to rule out a structural problem. But again, most people with chronic pain don't have a structural problem. In the area of back and neck, degenerative disc disease on MRIs is normal in healthy people. Bulging discs are normal in healthy people. Spinal stenosis, facet arthropathy, arthritis of the back, these are all normal in healthy people. So how do you know?
Can I inject a little side question?
Yeah.
Yeah, I remember when I was going through this, that my MRIs would show so many dislocated discs and so many fractures, even, lots of things. But actually, my pain had disappeared with my understanding of what was actually happening instantly.
Right. Yeah.
So how, but I didn't know, excuse me, what any of these things meant. You have like 5 dislocated discs and 20 of that one, and you
Right.
have 3 of this. I'm not a doctor. I don't know what that means. So how would I know the difference of what is a structural issue versus what is not? When a doctor is telling me all this terminology that I'm not familiar with.
That's why we need the two-step process. The first step is to rule out a significant problem, which would be a tumor, a fracture, an infection, an inflammatory disorder. The bulging discs, the degenerative discs, and doing a neurologic exam, make sure the muscles are normal, the nerve reflexes are normal, the sensation is normal. And so very few people have those problems. That's about 5 or maybe even 8% or 10%. So for the other 90%, their MRI is abnormal. But it's not one of those serious abnormalities. It's the normal abnormalities. So now how do we know? We take the second step. Well, the second step is to use what we call the FIT criteria, FIT, is we look at the characteristics of the pain. For example, if you have a broken shoulder, your pain is going to hurt all the time. It's going to hurt when you move it. It's going to be better at rest. The pain is not going to move from one shoulder to the other shoulder, right? It's simple things of if you have a physical injury. So when we have people who have chronic pain, we ask the simple questions. Does the pain turn on and off? Does it move from place to place sometimes? Is it better at different times of day? Is it worse when you think about it? Is it worse with stress? Is it worse with certain movements? But sometimes it's worse with those movements, but sometimes it's not worse with those movements. Like some people have pain when sitting in a chair. Well, sometimes it hurts in one chair, but not in a different chair. So we're looking for all these clues. Is the pain, is it made worse by the weather? Is it made worse by computer screens or the wind or cold? So we're looking for all these clues. And when you do that, you can almost all the time figure it out. And that's how you know. And I do this every day. I've been doing it for over 20 years. And so these criteria that we've developed are very simple to use. Anybody can look at them. And they say, the pain started in my neck and it spread all the way down my back. Well, and the doctors can't find anything other than these normal abnormalities. Well, that's easy, right? It's usually incredibly easy to figure it out if you use this two-step process.
So then what happens? It's easy, but it's painful, right? And sometimes excruciatingly painful. And people have this, oh, it's not in my head. I actually have this pain, right? So people confuse mind-body idea with people saying, it's in your head. You're creating it, doesn't mean it's in your head, right? Please tell us more about these. How is it what were we going to do with this excruciating pain, maybe that is totally debilitating? And
the first thing we do is we love our patients. We love them. We have to show that we care about them in order for them to listen to us. If you don't care about your patients, they're not going to listen to you. So we have to love them, number one. Second, we have to listen to them. We have to hear their story and understand their story, not just where the pain is, but also their life story, because we want to understand how their life has led to this. And we want to validate them and empathize with them and tell them that we can't, it's not that I don't know what your pain is like. I can't even imagine what your pain is like. And I know that that pain is real. And I know it's not in your head. And I know you're not faking it. And I know that you don't want the pain. And I definitely know it's not your fault. So we need to be very clear about this work that we're doing, because blaming the patient is the last thing that we want to do. minimizing the pain or minimizing their suffering is the last thing that we want to do. Once we do that, then we can explore together to determine if the pain is coming from the brain or not, because we then explain how the brain works. As people can begin to understand how the brain works. And this idea that I mentioned earlier about predictive processing, that our brains create what we experience. Most doctors don't know that. Most doctors have not been taught the neuroscience. This is hard neuroscience. This isn't woo-woo. This isn't new age or whatever. This is hard neuroscience of how the brain works and how the brain creates what we experience. And so when we do that, hopefully our patients will say something like, I'm so glad that this pain is not in my head. And I'm so glad that this pain is in my brain. Because if it's coming from the brain and not from a structural damage in the body, then it's reversible. There's hope. There's optimism. And when somebody like you reads one of Dr. Sarno's books and they get the education of how the pain, what the pain is, and they believe that it applies to them, and they get hope and optimism, and maybe they're seeing somebody who's a caring practitioner who cares about them and empathizes with them. Those are powerful mechanisms to turn off pain in the brain.
Please tell us a little more about how the brain works to create the pain, so that we really unpack this a little more. Can we?
Sure. So the neuroscientists call this the salience network. Salience means what's important. And our brain has a very difficult job. It's taking in information from the world at large. It's taking in billions of bits of information, vision and hearing, and the environment. It's constantly alerting. There's this danger signal in our brain that's constantly monitoring the world for danger. If you're walking down the street, you're just looking at the sky and the flowers, but the danger signal in your brain is on alert. You call it, you say, well, it's hypervigilant. Some people are hypervigilant, right? They're more sensitive and vigilant, fearful of their world. Well, the danger signal in the brain is hypervigilant all the time, whether you're aware of it or not. It's a subconscious entity in our brain. And if a car swerves toward you on a highway, or if somebody moves towards you as you're walking on the street, your brain instantly goes into that danger mode and reacts. So it's always there, it's always looking. So the brain is taking in billions of bits of information from the exterior world. At the same time, it's taking in billions of bits of information from your body. It's constantly getting information from the body. This is called interoception, from every part of your body, every hair, every cell, your liver, your spleen, your kidney, your nose, your mouth, everything is going into the brain. So it's monitoring that. And it also has billions of bits of information from your memories, from all your other experiences. And so it's putting all that together and it's trying to determine what to pay attention to at any given moment. It's filtering out 99.9% of all that information because you're not aware of all that. You couldn't be aware of all that. You'd go crazy. So the brain is constantly trying to figure out what to do, how to balance, how to budget, what to pay attention to moment by moment. And one of the first patients that I saw was a woman whose experience really blew my mind because she got headaches. She got a head pain when she got a new pair of glasses, a new prescription. She put the glasses on. Within a minute, her head started hurting on one side. And she had severe head pain every day for 17 years after that. Horrible. She went to headache doctors, clinics, medications, specialists. No one could help her with this pain. And it wasn't the glasses. They changed the glasses. They fixed the lenses. It had nothing to do with that. And when she came to see me, I asked her, well, what was going on in your life at the time you got the headaches? And tell me about your life growing up. Well, it turned out growing up, her mom was caring. She had a father who was very unpredictable. Sometimes he was kind and caring when he came home from work. And sometimes he was yelling and screaming and really angry with her and yelling, screaming right in her face, very unpredictable. And that's how she grew up. She grew up, she had no pain. She got married, she had kids, she was working, things were going fine. And then she got this pain when she put the glasses on. And I asked, what was going on in your life at the time you got this pair of glasses? And she said, well, my husband was fine, my kids were fine, they were doing okay in school, my job was fine. Well, I had a new boss. I said, oh, really? What was your boss like? She said he was very unpredictable. Sometimes he would be kind and caring and supportive, and out of the blue, all of a sudden something would go off in him and he would yell and scream, and it really scared me. And when she got that pain, the pain was a message from her brain, because pain is there to protect us, right? It's either protecting us from a physical injury or it's protecting us from emotional injury. And the message is to pay attention to where the danger is. But the pain doesn't tell us where the danger is. The pain just tells us there is danger. It's up to us to determine what the danger is. So when we were able to hear her story and understand why her brain started that pain, because of the trauma she has as a kid, of the memories of the being a male, of a powerful male being unpredictable and threatening, which then reoccurred later in her life. Her brain had all those memories. It had what was going on, and it was trying to help her. How was it trying to help her? By making pain. What was the message? Change jobs, get out of there. It's dangerous. You shouldn't be there. But she didn't know that message. She just knew she had headaches, so she went to doctors. And doctors couldn't tell her why she had that pain because they didn't understand how the brain works. They weren't looking for this kind of thing. They were just saying, you have pain, we'll give you medications or injections. So that's how the brain works.
Yeah, and the glasses were just the excuse. Here's the glasses. Okay, start the pain now. Or maybe she, going back to it, she thought it was the moment when the glasses turned out it was just a
It was a trigger.
coat.
Getting the
Yeah,
new glasses was a trigger for her.
yeah. Maybe there was a glasses somewhere in the story.
Instead of the glasses being a trigger, it could have been she bent over to pick up
Right.
a box and she could
Yes.
have gotten back pain,
Yes.
right? Or it could have been stomach pain. It could have been anything.
Yeah.
Because why would the brain produce pain? We know that the brain can produce anxiety when you're in a stressful situation. Everyone knows that. We know that the brain can produce depression or burnout when you're in a stressful situation. Everyone knows that. But what most people don't realize is the brain can also produce pain or fatigue or insomnia or a whole host, ringing in the ears or diarrhea or frequent urination or burning sensations or tingling sensations. There's millions of different ways that the brain can create a warning signal. Yeah. But why would the brain do that to an emotional injury? Well, we don't know, but that's how we evolved. What we think happened, a speculation, which is interesting, is that we know the brain produces pain when you get an injury because it's a message to stop running on a broken ankle. Very important. If you don't get pain when you have a broken ankle, you'll die. You'll have severe consequences. But back in, 100 or a couple 100,000 years ago, literally, human beings lived on the earth at the same time as Neanderthals. And Neanderthals were bigger, faster, stronger, had bigger brains even. They were a better species, but humans survived and Neanderthal died out. Why did humans survive? Because they worked in clans. They operated together to hunt, to raise children, to defend themselves. And those clans were how they survived. So to get kicked out of the clan is like a death sentence. And why would you get kicked out of a clan? Well, if you beat up somebody or killed somebody or slept with someone's wife, I don't know, beat up a child, whatever, if you did something wrong, and you would get kicked out of the clan. And so the brain developed this powerful way of giving pain and other symptoms from emotional rejection, from physical rejection. And that's why it's so difficult for people when they feel rejected, when they feel left out, when they feel hurt emotionally, when people don't pay attention to them or neglect them or hurt them or betray them, right? Those are the things that cause emotional hurts, that can cause real physical pain.
And, in my experience at that time, when I recovered also, it made so much sense to me that the emotional pain of what had caused my physical pain was so much more dense than the physical pain. The physical pain, as horrible and debilitating as it was, the emotional pain, when I understood what it was that triggered me, I understood also how back, a year back from that, I would not have been able to process that emotional pain. It was preferable to have the physical pain. I mean, this sounds kind of weird in a way, because when the physical pain is so intense, but actually the emotional pain was just something I couldn't have handled. I just wouldn't have been able to emotionally handle that pain. So when I was actually came to a place when I was able to face that emotional pain, then I was able to also understand what it was and
Right.
face it. So yeah, that may be one of the things. Yeah, we
Doctor,
may
yeah.
prefer the physical pain to the emotional one,
Well,
if
Dr.
that's the case.
Sarno, one of Dr. Sarno's theories was that people, like you say, can't handle the emotional pain is too severe. And so that the brain creates physical pain as a distraction from the emotional pain, or as a defense mechanism to deal with the emotional pain. And one of the treatments, there's two main treatments you mentioned earlier that we do:
Yes,
pain reprocessing and emotional
yes.
awareness and expression. In the emotional awareness and expression therapy, we're helping to uncover those emotions and help people actually feel those emotions in a safe and healthy way, and express those emotions so that they can release them. And this can be extremely healing for people to do that work, because we're getting to the underlying source of the problem.
Please tell us more about those two processes. And maybe even if you would like to give us a little taste of something that we can feel into and experience, rather than just mentally understand.
Sure, of course. Yeah, that's a great idea. So the pain reprocessing is what we usually start with. And that involves, as I said, first assessing people, making sure that we're treating a mind-body disorder or a nociplastic disorder rather than a structural disorder. And step one, then we're giving them explanation of how the brain works, predictive processing. And then what we want to do is lower the danger signal, lowering the neural circuits in the brain that are causing the danger signal. And it turns out one of the best ways to do that is to lower the fear of the symptoms. So there's a vicious cycle that occurs when someone has pain or fatigue or other symptoms. Then they're afraid of those symptoms. They anticipate those. They worry about them. They fight them. They get frustrated by them. They are trying to fix them. They're trying to figure them out. They're on their mind constantly. They're focusing on them. So all those things actually lead to more of the symptom in a vicious cycle: pain, fear, pain. So the PRT work is to identify that those reactions to the pain are detrimental, and they're not necessary, because the pain is a false danger signal in this case, right? It's not because of physical injury. It's because of these learned neural circuits in the brain. So one of the things we do is one of the things I do is I give people, once I've gone through all this, I give people a quiz. I say, okay, I'm going to give you a quiz. It's one question. I'm going to give you the answer, and then I'm going to ask you the question. So the answer is nothing. And then I'll say, so tell me, what's wrong with you? And they say nothing. And I'll say it louder. Say it louder. How does that feel? And they'll go, it feels like I'm lying to myself because I have all this pain. So then we go back and we explain again and understand where the pain is coming from. And then I'll say, let's try it again. What's wrong with you? Nothing, nothing, nothing. Okay, is that the truth? Well, I'm worried about my MRI findings. Okay, well, let's talk about that. Let's explain that. Let's make sure that we're all on the same page. And after a while, when we go through that, most of the time, I'm able to say, hey, what's wrong with you? And they say, nothing, nothing, nothing. And I'll say it in Spanish, nada. Say it in French, rien. Say it in British, My fair lady, there's absolutely nothing wrong with you. Say it in Australian, oh, good day, mate. Ain't nothing wrong with you. Say it in Southern, oh, honey pie, you're going to be all right. So what we're doing is we're sending these powerful messages to the brain in a playful way to say, hey, you're okay. You're safe. You're not in danger. And that starts to turn off these danger signals in the brain. And it sounds silly, but it's powerful, right? And we give them affirmations to say to themselves, because affirmations actually change the brain. And then if you want an exercise, so anybody can do this at home. So let's say do you have any pain right now, by the way?
I do. I have not right now. I don't have pain right now, but I have an issue on my left knee.
Okay. Well, maybe there's damage to your left knee. I don't know. Does the pain come and go? Does it turn on and off? Is it variable? Does it sometimes hurt when you walk and sometimes not?
It's swollen and it hurts more sometimes than others.
Okay. Well, we would need to take a little more time and figure it out. We need to look at your x-rays or your MRIs, but we can do it with you just to see what happens. And anybody who's watching this can do it if they have a pain or a symptom. Okay. So what you want to do is you want to take a trigger to that symptom, a trigger to the pain. Let's say walking upstairs or walking up a hill tend to cause it?
Sitting causes it, actually.
Sitting?
Yeah, and I'm sitting, so.
But you're sitting right now and you're not having it.
No, I'm not having, but as soon as I get up, I will, probably. And I have a big history of mind-body pain sort of thing, so I'm very skeptical about my.
So you would get the pain if right now, if you stood up, you would have some discomfort, right?
Yes, I think so.
Okay, let's play with that. Then anybody at home can take a trigger. If their trigger is sitting or walking or standing or twisting or bending, if their trigger is cold weather or visiting a relative, whatever the trigger is, you can imagine it. So what I want you to do is close your eyes. Okay. And now what I want you to do, you're not going to move or anything, but I want you to imagine standing up quickly right now. Imagine standing up quickly. Okay. Just imagine doing that. Okay. You with me?
Yes.
Okay. And now tell me, do you have any reaction to that? Do you get any discomfort, any anxiety, any tension, or is there no reaction? What do you notice?
I had both. I had one where I had the reaction, and the second one I just jumped up and there was nothing wrong because I was prompted with your earlier.
So open your eyes, explain to me what happened. You said you did it twice.
I did.
Interesting. The first time you had a reaction, right? What reaction did you have the first time you did it?
That I limped on my knee.
Did you anticipate you would be limping, or did you actually feel some discomfort with imagination?
I didn't feel actual discomfort. I was just visualizing.
That it would be, you visualized.
And I got up and I limped, and then I corrected myself. I got up and didn't limp.
Right. So what you did is exactly what I would do. So the first time we run through it, people generally have a negative view of what's going to happen, anticipation. Sometimes they'll get a symptom. They'll actually get discomfort by imagining it. Sometimes they won't. But either way, I'll say your brain is afraid of that, or it's been afraid of that. So now what I want you to do is imagine it the second time, but this time take the quiz, do the affirmations, put yourself in a positive place. Imagine that you're standing up with joy and freedom. And that's exactly what you did. And did it feel better the second time versus the first time?
Duh.
Right. So now what we want to do is I'm going to say, hey, what's wrong with your knee?
Nothing.
Good. Say it in French. Say it in Spanish.
Bien.
Good. Nada. Good. Ain't nothing wrong. You're okay. Right?
Yeah.
And put a big smile on your face and say, I'm safe and I'm not in danger. I'm safe and I'm not in danger. Right? Say that. Right?
I am safe and I'm not in danger.
Good. Now I want you to stand up with joy. Literally stand up with joy. Yay. And see how it feels.
Did too.
And how did you feel?
I felt nothing in my knee. At
because
all. Like it was just as good as my other knee.
so that's pain reprocessing. Part of pain reprocessing therapy in a nutshell is that, and I call that provocative testing. And you can find that in my books and find that in our other things we've written.
Yes.
And we have research showing that pain reprocessing therapy is extremely effective in lowering nociplastic pain syndromes. We have one study with back pain, and 75% of the people who got this treatment were pain-free in 1 month.
Yeah.
So, that's
That's
PRT in a nutshell. There's other parts of PRT. We want people to move with less fear. We want people
yes.
to gradually do more and more with less fear.
Mhm.
We want them to notice the sensations with less fear and tell themselves, that's my brain. I'm not in danger. This is a false alarm. I'll be fine. There's a variety of things, but
Yes.
that's the essence of pain reprocessing therapy.
Beautiful. Beautiful. Is this somehow related to the what do they call it? The water pill thing? When you
Placebo
know
effect?
placebo effect, yes. Is it?
Well, all treatment has a placebo effect component to it. And number one. Number two, the placebo effect can be extremely powerful. Number three, if you have a mind-body disorder, all you need is a good placebo effect because you don't need medical treatment.
Yeah.
And the placebo is marshaling the power of someone's brain. So if someone will say to me, Dr. Schubiner, you just are offering placebo, I'll say, yes, of course I am. And it works.
Yes.
Because I'm helping people marshal the power of their brain.
Beautiful. Yes. Beautiful. Well, let's see. I'll take my question. I've heard you somewhere. What would you like to close with? Our time is gone, so we have to decide how we can close. Is there something you would like to close with?
Well, the other thing I would say is that we didn't have time to touch on the emotional awareness and expression therapy.
Please, let's do a little bit.
And it's important to understand that the underlying, you can make the pain go away by using the PRT, but if there's underlying trauma, underlying ongoing stress, underlying things that people are upset about in their lives, the pain will tend to come back, or it may come back in a different place, or a different symptom may occur because you haven't corrected the underlying process. And for example, the story that I've been telling lately is that about a year ago, my hospital came to me. I've been at the hospital for 20 years, and they came to me and said, we can't hire you anymore. We have to let you go. We can't afford this. We're in budget crisis. It's not personal, but your contract will not be renewed and you have to leave in 1 month. And, I've been there a long time. I worked really hard. I've developed a lot of programs there, research. I've done a lot of things, and people thought highly of me there, but nevertheless, that didn't matter because the hospital runs on money. They weren't firing the back doctors who do back surgery. That maybe not be necessary. They weren't firing the injection doctors or the pain medication doctors. They were firing me. Not firing, but letting me go. And 2 days later, I got back pain. And, it really wasn't surprising when you think of it. So I did the pain reprocessing work for myself. I started telling myself I was okay, I was safe. I kept walking, I kept bending, I kept moving, I kept telling myself I was fine. And 2 weeks later, I was still having a lot of back pain. And I realized that I was telling people that, the hospital let me go. And isn't that funny? The hospital let me go. Isn't that funny? Isn't that odd? They let me go. And then I realized a couple of weeks later, it's not funny. I have some feelings about that. And these feelings were not being expressed. They were being held in. And those feelings were coming out in back pain. So I had to do emotional awareness and expression therapy work for myself. So the first thing I recognized that I had some feelings. And one feeling I had was anger. And I was just holding down that anger. So I decided to identify that anger, experience that anger, and express it in a safe and healthy way. How did I do that? I was in my car. I was alone. I started screaming. I started yelling. I was swearing, F the hospital, F this, F that. I was just screaming and swearing, letting out all my anger toward the hospital, toward the system, toward the administration, toward all the other doctors who don't get this. I was just letting out all my anger. And then I took the anger to a much higher level, and I imagined blowing up the hospital with TNT, like in a cartoon. And then I laughed, because then I could let the anger go. And I didn't do anything dangerous. I'm not going to jail for imagination, right? And then I could let the anger go, which was very healing. And then there was another major feeling that I had, which was sadness and hurt, being kicked aside, not being wanted, being rejected, as we talked about earlier. So I started allowing those feelings to come in instead of pushing them down. So I allowed myself to feel the hurt and feel the sadness. And it brought me to times of other hurt and sadness that I'd had at different points in my life. And then that sadness, anger is a call to protect, to defend yourself. Sadness is a call to connect and to be caring and loving and connecting. So what I did then is I started connecting to myself. I started giving myself messages of compassion and caring and kindness. And I happened to, a friend called me right around that time, and he started giving me messages of caring and kindness and connection, and saying how sad and wrong it was for the hospital to let me go. And as I replaced the sadness with compassion, I got home and my back pain disappeared. So that's an example of emotional awareness and expression therapy. And you can do that not only for things that are happening in your current life, you can also do it for things that happened a week ago, a year ago, 5 years ago, 50 years ago. And we use this process called memory reconsolidation, where people can go back in time and give compassion and caring to their younger self. They can go back in time and stand up for their younger self and express any anger or rage about how they were being treated at that time, and take that child away to a safe and healthy place. So, and it's a form of trauma treatment, obviously, and it's a way to reprocess the emotional memories that occurred in the past. You can't change what happened in the past, but how we know what happened in the past is our memory of it. And memories are constantly changing. Scientists know that. So we're purposely giving people ways of empowering themselves, changing their former memories to process those difficult times in safer and healthier ways, and not holding down the emotions, but letting them up and out. So in a nutshell, that's that. Yeah.
So beautiful. And you do all of this work as an MD.
I do, yeah.
Yeah, yeah. What a beautiful world when MD meaning is this.
Well, most physicians don't do this work.
We know they don't. Yes.
But we're training physicians, we're training psychologists, social workers, we're training coaches, we're training physical therapists, acupuncturists, massage therapists. We're training a lot of people to do this work because it makes sense. It helps people. It's not that difficult to learn, and many, many people need it.
Yes, yes. Thank you so much. Thank you so much. And lastly, please tell us you have a free gift.
I have a gift for you. Yeah, we can. If somebody,
I think I saw that you have a coupon for a discount on your book.
That's it. Yeah,
yes.
Yeah. You can put that. You can give that coupon to your listeners, and they can get. I think it's $10 off of one of my books.
Yes, yes. I'll go get mine.
Okay, awesome.
Yes, beautiful. Thank you so much, Dr. Schubiner.
Thank you for having me. Okay,
Yes.
Take care. Bye-bye.
Thank you, everyone.